Okay, good morning. Thanks to everyone for joining us today. I'm Dr. Sarah Evans. I'm an assistant professor in the Department of Environmental Medicine and Climate Science at Mount Sinai and a member of our Research Institute for Climate Change, Environmental Health, and Exposomics. I'm pleased to serve as the moderator for today's presentation, and I have the honor of introducing Dean Rosalind Wright and sharing the exciting news that Dr. Wright has recently been appointed the inaugural Dean for Public Health and chair of a new department of public health at Mount Sinai. Mount Sinai's long history of public health research and education has played a major role in attracting top-notch clinicians and researchers to the institution, and it is really an exciting development for us all to have a transformative leader and champion of environmental health and exposomics like Dean Wright at the helm of this expanded effort. Dean Wright is an internationally recognized clinician scientist and life course epidemiologist with transdisciplinary training in molecular biology, environmental health, and stress mechanisms. She has broad expertise in environmental exposure assessment, as well as genetics, epigenetics, and the application of psychosocial stress measurements to environmental health studies. A major focus of Dean Wright's research is the role of social risk and resiliency in programming chronic disease risk. Her work has led to major advances in how we think about environmental health by looking at how factors such as psychosocial stress, social networks, and socioeconomic factors act alone or in conjunction with physical environmental factors such as air pollution, nutrition, allergens, and chemicals to impact health across the lifespan. In 2012, Dean Wright established the Physiological Assessment of Children's Environmental Risk, or PACER laboratory, focusing on the assessment of key regulatory biological response systems in pregnant women, infants, and children. Her research has been supported by uninterrupted funding from the NIH for 23 years. Dean Wright received a Bachelor of Science in Human Genetics at the University of Michigan and her medical degree from the University of Michigan Medical School. So, Dr. Wright, I will turn it over to you.
Thank you, Sarah. That's a lot. Thanks for the introduction. And thank you all for joining us today. We're going to be talking about a very important topic, and I think an understudied topic when it comes to environmental health, and that is perinatal mood disorders in women. It's a particular time in a woman's lifetime when she's at risk for developing psychological disorders. And we're going to talk specifically today about depressive disorders, but we'll touch on some of the others. So let me just share my screen and get my slides up for you. Can we see that okay in presentation mode?
Yes.
Okay. And you can hear me okay?
Yes.
Yeah. Somebody let me know if that changes. So we're going to talk today, and I want to start to present on understanding postpartum depression and particularly environmental risk factors for depression and the multitude of factors that might contribute to development of perinatal depressive disorders. And then I hope we can discuss together some public health solutions to protect new mothers. We'll touch on briefly some, but that I hope is going to be part of our discussion. So let's see. It's not, okay. Slides are advancing for you?
Yes.
So let's start just understanding a little bit about what we'll be talking about today, specifically perinatal mood disorders and particularly depressive subtypes. And why do I say subtypes? Because we're understanding that's a little bit more complicated and we have to actually unpack the different, it's a range of symptoms that folks can have, and that may have different implications for what might be causing it, what are the mechanisms underlying in pathways, but also how people might respond to the treatments we have. So mood disorders are very common, as I said, in the peripartum period. It's a particularly high risk period for women, including major and minor episodes in the prenatal, antenatal, and or within the 12 months after delivery, which is the postpartum period. It's about 20% of antenatal depression is what the surveillance data will tell us. There are certain populations, as we'll talk about, that are even at higher risk. And then postpartum depression ranges from 12 to 18%. A recent pooled global prevalence has been estimated at around 18% at the high end, with a reference that you see there. And when we talk about postpartum depression, it's like depressive disorders in non-pregnant samples. We see both unipolar and bipolar disorders, and those occur at 9% and 3% respectively. And the reason to understand that as we do our research is because the risk factors can be quite different for those different types. But evidence is increasingly demonstrating that we need to consider other subtypes of depression, and particularly something called anhedonia, which is indexed as reduced interest or pleasure in previous things that you enjoyed doing. Maybe you enjoyed gardening, but no interest. You're a musician, you lose interest in that, but also other things, relationships, etc. Those that were previously perceived as rewarding no longer give you that sense of pleasure and happiness. And that's consequent to a different pathway that's been identified in the brain that can be disrupted by the different environmental factors that we'll be talking about. It's reported anhedonia occurs in approximately 30 to 50% of non-pregnant samples. This is something that's been parsed out a little bit more, disentangled from the more classic depressive symptoms in non-pregnant samples, and they're just starting to look at it in pregnancy so we've become much more interested in this. And studies of anhedonia in pregnancy currently estimate almost a quarter of women might have this subtype who are experiencing significant depressive symptoms. Anhedonia is associated with more severe depression and poor response to treatments. That's why it's very important to identify this. And it may be a surrogate indicator of future depressive illnesses. For example, if you can identify women who have prenatal anhedonia subtype symptoms of depression, they may be more likely and at higher risk for depression in the postpartum period. Now, Sarah mentioned that one major focus, area of interest for me, I do look at a lot of psychosocial stress, chronic financial strain, relationship difficulties, exposure to trauma and violence. These things have classically been linked to psychopathology, higher anxiety, higher depression, those sorts of things. There's a huge amount of literature, if you look at the perinatal mood disorder literature, on stress, psychological stress, psychosocial stress, both at the individual, community level, etc., predicting higher levels of depression. But really what hasn't been done is shown in this cartoon. There's so many other external environmental factors that have been linked to disruption of brain and central nervous system pathways that can manifest as psychological symptoms, neurocognitive symptoms, etc. That has not been looked at in this particular state of pregnancy-related psychopathology. And that was a gap that we thought we needed to start to explore. So you can see a whole host of list of things there, both outdoor air pollution exposures, indoor factors, etc. We're gonna talk particularly about ambient air pollution today, but we really need to start looking at multiple factors together. As Sarah mentioned, you can see compounded risk if you live in an environment that's both got higher psychosocial stress and higher chemical toxins like air pollution. So here we did a study. We have a cohort that we've been following for a couple of decades now in the Boston metropolitan area, the Asthma Coalition on Community Environment and Social Stress, originally designed to look at what risk factors for asthma in kids. But one of the things we found was there was high levels of maternal psychopathology, including perinatal depression. So you can see the dots on the map there. That's where folks are living across that Boston metropolitan area. We actually used satellite-based spatial temporal land use regression modeling. It's just a fancy approach to looking at estimating air pollution exposure where those women were living during pregnancy. So at their residence, we estimated daily particulate matter. Particulate matter is fine particulate matter has been linked to multiple disrupted brain mechanisms that can relate or transmit to neuropsychological symptoms in non-pregnant samples. So we thought we'd look at it as well in our pregnancy. And we measured it with a scale that's been most widely used to look at depression in this period, the Edinburgh Postnatal Depression Scale, and you can see the details there. The nice thing about it is it's 10 items, and you can actually do factor analysis and break out the items that characterize more classic depressive symptoms, and then anhedonia, the loss of pleasure and things. So we were fortunate that we used that scale so we could parse this out. This shows you a cartoon version of how we estimate those air pollution exposures for our participants, and it's using NASA satellite-based measures linked to, as you can see in the map on the lower left-hand corner, across the northeastern United States, including Massachusetts. The dots are stationary monitors that our Environmental Protection Agency, the EPA, has around, and that helps us calibrate the measures that we get from the other things that are going into these models. At the top, the squiggly lines, different colors, just shows you that's each woman's exposure across the pregnancy, the gestational period, and it just shows we can see variability to when and how much people are being exposed to, when linked to their address. And then we can actually then take those estimates and use statistical modeling to look across pregnancy, which is each of these graphs on the axis at the bottom for looking at both total depression score and anhedonia, as well as the anxiety and depressive subscales in that Edinburgh Depression Scale. I want to draw your attention just to the upper right-hand corner under anhedonia, where we're circled in blue. The blue just shows you that's the one thing that showed that there was elevated risk of anhedonia symptoms in our women in the postpartum period, in the first 6 months postpartum. We didn't see it for the total depression scale, and we didn't see it when we broke out the classic depressive symptoms either. So it really seems to be driven by this subtype of anhedonia, which is important to start to identify, as we talked about earlier. And then we looked within our racial ethnic categories, because there's a lot of literature that suggests that both folks that live in lower income communities and households, as well as ethnic minority populations, including African American and Latino populations, which sometimes you can't disentangle because they are the ones living in some of these lower income communities as well. So they might be exposed to higher levels of not only psychological stress, but and we'll show a little bit below that we've actually looked at it in this population. They're also more highly exposed to toxins like the air pollutants that we're looking at. And we actually saw that for anhedonia, well, here we're looking at the total depression scale, but it was similar for anhedonia. It was really in our African American population in this cohort that we were looking at in the northeastern United States, Boston metropolitan area, that was at higher risk. So the air pollution, and maybe it's differential exposure to air pollution, or maybe it's compounded by the underlying stress. These are things we'll have to sort out in future work. But we wanted to at least get something in the literature to start getting people to look at some of these chemical pollutants as drivers of increased risk for these outcomes. But then we need to move towards sort of more comprehensively assessing the factors that might be driving this. And real life air pollution exposure is to a mixture of pollutants. You breathe a lot of things in the air as we walk around outside. That's put into that air through traffic related pollutants, industry related factors, wildfires that we experienced here on the Northeast this past year because of the wildfires burning in Canada on the East Coast. Not something we typically do, but more and more we're going to experience those things because of climate change. So we have to start thinking about looking at mixtures of these chemicals, and our group, our statisticians and bioinformaticians have come up with new approaches that can actually look at multiple pollutants at the same time, even that are differentially spatially distributed across the different areas, the different neighborhoods, communities, regions of the United States that we're looking at, but also as high, daily. We can look at it as much as at a resolution of daily exposures, not averaged over, say, the whole pregnancy, or because you might miss things. Co-occurring pollutants need to be looked at because they interact in complex ways. And when you have a mixture effect, you can actually see effects on our health, even if all of them are levels below what we anticipate individually would have observable adverse effects. And so failing to look at joint exposures, you can get misleading or even missed effects. We'll talk about as well why we think differential exposure to these things have occurred in certain neighborhoods. There's been historical policies resulting in disinvestment in certain minority communities historically, particularly African American communities, through housing loan policies back in the 50s, 60s, 70s, which have contributed not only to past differential exposures and disparities in exposures to environmental toxins, but you can see that they persist even today in our communities, and we'll look at that in our population. So we broadened our exposure assessment to consider not only just one pollutant, fine particulate matter that had been linked previously to brain disorders, but also started to look at multiple components of what is in PM 2.5 that are monitored routinely by the EPA. And then we also looked at some of the gaseous pollutants like ozone, which we know can have impact on our health, and nitrogen dioxide. So we went back to the same cohort in the Boston metropolitan area, the Access Project, but we combined that with another cohort we started recruiting subsequently that was standardized in its approach to measuring the same factors, including maternal depression during pregnancy, and we had modeled air pollution exposure. Now, this is across the Boston metropolitan area as well. You can see the multiple pollutants that we looked at. We looked at nitrate, sulfate, elemental carbon. They're all listed there, the different pollutants. But just keep in mind, we're looking at 7 different pollutants, daily exposures, and we're looking at that same Edinburgh Depression Scale outcome in our mothers, both pre and postnatally. And then we looked at a mixture, and you can see that they're mapped, the different pollutant exposures again for the participants that we had recruited into this. And as you go from the green to the red shading, that's where you get higher levels of air pollution. Green is low, red is, orange is in red, it gets higher exposures. And so you can see each pollutant has its own particular pattern of exposure across those folks. So each of them are going to be experiencing a little bit different mixture across some of those communities. And what we found was very interesting, because we had to actually take into account some higher order interactions. We had to think about different individual factors that might modify the risk of the air pollution exposure. And here we looked at child sex. So in the sex of the fetus that the mother carried during pregnancy, her exposure to the air pollution mixture. And we also looked at race, ethnicity, because we know from our literature and from what we're already finding, there's differential risk, particularly in our minority populations in this cohort. And what we found was quite interesting. It was particularly Hispanic mothers who were carrying a male fetus during the pregnancy who had higher risk for postpartum depression when exposed to the higher levels of the air pollution mixture. And then on the right, you can see which pollutants were driving that. And it was really sulfate and ozone in there. Now, why would we want to do that? Why would we want to use our mathematical modeling to actually have it tell us what are the driving pollutants? Well, this will help folks make decisions on policies around reducing some of these exposures in our communities, or talking to women to minimize their exposure, and or trying to identify things that might protect, even though you are exposed to these different cocktails of the air pollution going forward. And if we have time, we can touch on why carrying a male offspring might be a risk here. It's not that you're having a boy. There's biological differences between what the mother experiences physiologically during the pregnancy, whether she's carrying a boy or a girl, hormone patterns, and those sorts of things. So that's probably driving some of this differential risk. Now, here's why we really want to look at air pollution mixtures across wide areas, because it can vary in what the levels of these pollutants are and what the cocktail might look like in these areas. And it might differ by race, ethnicity, who's living in which communities. It really is where you live. That seems to be the factor that's driving that. So here's we show 3 pollutants: the PM2.5, the NO2, and the ozone over on the right in New York City, Boston, and suburban area. Boston and New York City are more urban, lots of traffic, those sorts of things. The Virginia population on the bottom is more suburban. And we looked at that levels of exposures to those by race, ethnicity, and you can see that depending on which pollutant you're looking at, some of the ethnic minorities, which are in the pink and the grayish color, versus the light blue, which are the white populations, you can see there's differential exposure. But you also see those differential exposures vary whether you're looking at New York City, Boston, or this suburban area in Virginia. So identify the pollutants in a mixture driving health effects in a particular geographic region and by race, ethnicity might point to certain source-specific effects that inform health inequities and guide more targeted regulatory intervention policies. So we definitely got to stop thinking just one pollutant at a time, look at what is more reality, multiple pollutants, and also understanding that these vary geographically. And we talked a little bit about the housing loan practices, which were called redlining. Basically, the housing authority that set these up for making bank loans for home buying in the 50s set up these residential security grades. A is best in green, the green color that we put in the graphics below. B still desirable in the blue. C definitely deteriorating in the orange, and D hazardous or red, which is why they call redlining. And basically, it was more difficult for folks to get loans for homes, and there was lots of other ways they disinvested in these communities. The homes are more dilapidated. There's more exposure, industries moving in, traffic patterns, et cetera, that contribute to things like air pollution. And down below, you can see that all of the pollutants that we looked at, if you look at the grade of today across that population in the metropolitan Boston area by color, A, B, C, D, you can see that air pollution exposures are higher in the orange and the red communities, even to this day. So that those policies have had far-reaching effects, and we need to actually be thinking about them even today for these communities. Ultimately, we need to reinvest more in these communities and do things more targeted to decrease their exposure to these toxins. Well, it's not just, I'm going to put in a couple slides to show we're not just thinking about air pollution. We're not just thinking about psychosocial stressors. We know those are both driving some of the psychopathology that we're seeing in this particularly critical window for women in the perinatal period. But also metal exposures. So we also took a look at heavy metal exposures to, in the abbreviations there, barium, cadmium, chromium, cesium, lead, and antimony are the different metals that we're looking at. Again, we're looking at not only individual effects of each of those metals, if we look at them one at a time, which are the top lines. And if you're on the right-hand side of that dotted line, which is at 0, you're at increased risk. In this case, it's for anxiety in pregnancy. It's not depression. We did look at depression with the metals, and it seems that the metals exposure have impact on different pathways in the brain that may lead to more anxiety-related symptoms in these women. And you can see almost all of them had higher risk because they're shifted to the right of that dotted line if you looked at them independently. But when we looked at them as a mixture, which is labeled as WQS, which is a weighted quantile sum approach that we use to calculate the mixture effect, you can see that the percent change in odds of having high anxiety symptoms measured by the Spielberger Trait Anxiety Index, that's what STAI stands for there, there's increased risk. You can see it's higher when you consider it as a mixture together, which is, again, more reality. And that cadmium, and again, these models can show us which particular metals are driving the effects, and it was really cadmium and chromium. So, and this will be different in different areas as well, because you can look, and we've published on this as well in the same population, racial, ethnic, and neighborhood disparities in metals exposure during pregnancy. Now, these are just pregnant women coming in for their routine prenatal care. We take urine samples as they enroll into our studies, and you can actually look at metal exposure levels in the urine samples that we're getting during pregnancy and relate that to differential exposure based on your level of education, which is at the top, circled in the blue rectangle. When you compare less than high school education to some college, you can see that those women have higher levels of exposure to almost all of the metals, as well as the high school versus college education. And then you can actually see racial ethnic differences when you look at the bottom rectangle that's circled in the blue, and it's shown here in this graphic as well. Percent change in urinary metal concentration during pregnancy among Black, Hispanic, and white Hispanic participants are higher for almost all except for arsenic and barium when you compare them to white non-Hispanic participants. So again, these women are coming in, and we have to start understanding and looking for differential exposure to these environmental toxins to both, counsel women on risk, but also to start to think about how we might protect them. We always think about it now for protecting the unborn baby. There's been a huge amount of research, but again, these are also having an impact on maternal health and maternal psychological health in particular, which has been ignored, I think, when you think about environmental health. So here it just shows another project we're involved in. Those cohorts that I talked about before, we're looking at each, our smaller cohort, about 1,000 women in each of those cohorts. But there's been a national effort to pull together a national cohort across the United States, the environmental influences on child health outcomes, but we do measure maternal outcomes as well, particularly psychological functioning in this context because of its implications for child health going forward. But we can actually take advantage of some of the environmental exposures and start to look at maternal health as well. So this maps airborne lead exposure across the country. And again, you see from the lighter shading to the darker shading, you see a gradation in exposure to lead. Lead is a big part of air pollution exposure. So we can actually start looking at this across this very broad regionality, which is going to be very important when we are starting to target more what might be driving some of these health outcomes in women. Now I'm going to turn my attention a little bit to how we're thinking about, well, what can protect women? Yes, we can reduce air pollution. You can affect policies around that, et cetera. But you can imagine those things take time. People aren't readily able, oftentimes, to move out of their communities. They may not, have control over that, even though they know these things are there. So, as a clinician and a practitioner, et cetera, a public health practitioner, you really want to also start to identify resiliency factors. One of the things that can protect women is some of the things Sarah mentioned at the top, social supports, et cetera, which we know decrease stress. I'm not going to show you the data for that, but we have shown that if you're managing stress, you have low levels of stress, or you have high, social supports, et cetera, which buffer stress or other buffers of stress, you can actually mitigate the effects of toxins like the air pollution. That's one thing to think about here. But another thing we're going after is diet and nutrition. There's a lot of evidence that things like air pollution, heavy metal exposures impact our health adversely because they enhance things like oxidative stress. So you can increase antioxidant intakes in your diet. That's healthy for lots of reasons, but it can actually mitigate effects of some of these toxins. But one that's been getting more attention, particularly for pregnant women, is iodine intake. And iodine intake has been very something of interest in pregnancy because of its implications for child brain development. If there's inadequate intakes of iodine or iodine deficiencies in women, we know it has impact on the child, the developing brain. But no one's really looked at iodine in relationship to maternal psychopathology. So again, we're not thinking about the same factors that we know are affecting the brain development in the developing fetus, but it can have implications for the mom as well. And there's a lot of surveillance data from national screening programs like NHANES that show that about 25 to 50% of women may have below the recommended estimated average requirement threshold for pregnant women. It's higher. The needs are higher in pregnancy, both because the mom has increased needs for iodine and to maintain adequate thyroid function, and you have the fetus requiring more of this as well. And you can see there in our cohort, shown by their levels of exposure in 160 micrograms per ml is the EAR, the estimated average requirement intake, daily intake for women. You can see that about 25 to 50% had iodine deficiencies or inadequate intakes. It was closer to 25% if they were also taking iodine supplements, rather than just relying on dietary intake alone. But still, there's about a quarter of them are below the levels. And then we related that to postpartum mental health outcomes. The graphics on the right are a little bit complicated, but just to tell you what that's showing is that the iodine deficiency, relative to deficiency, both at the low end, too little iodine, below the EAR, the estimated average requirement, which is the two dotted lines that you see in the middle, would be the level of adequate intake in mothers. And you can see it kind of goes up on both ends for both pre-pregnancy and postpartum depression symptoms, as well as anhedonia. And that tells us that too little or too much might have adverse impact on psychological health. And we can talk about why the too much might be, but we already touched on why too little might be. We actually have shown that even if you're exposed to the higher levels of air pollution, if you can actually maintain, or if women have maintained adequate intake of iodine, you can protect against some of the neuropsychological outcomes that we're looking at. So what we actually need to start looking at is a mixture of all the micronutrients that are important. We know antioxidants are going to be important. We know that certain anti-inflammatory polyunsaturated fatty acids could be important to protecting the maternal brain. We know this because there's data to show that it does protect brain development in the developing child. But let's focus it back on mom and do some of that same work so that we can identify resiliency factors in these women. So again, let's get back to this. We have to get to a point where we're really moving towards a more exposomic approach to what drives some of these health outcomes, including the major problem, recalcitrant rising rates of peripartum psychological dysfunction in women in particular. Ultimately, we will look at mixtures by mixtures by mixtures. So we'll be looking at multiple air pollutants, mixtures of other toxins that we know affect the brain, like metals, mixtures of psychosocial stressors that might be driving this, and be able to parse out in certain particular population, what seems to be the big drivers so that we can intervene. You can also see the picture of the pregnant woman with the growing baby. They're under internal environment. We also have to work with our laboratory scientists to use high dimensional approaches to being able to measure multiple factors through things like metabolomics, microbiome, et cetera, as shown there. We didn't touch on that today, but that's a big part of what's going on. And so we need to, for peripartum depression, start to take the same exposomic look and scale it up and look at multiple factors, because we know that's more reality to what we're exposed to. And it's going to be able to get us down to maybe not an individual level, but subgroup levels where we can identify what those driving factors on and sit side by side with folks, public health practitioners, healthcare delivery providers, as well as government agencies, et cetera, where policy has to change. to do this. So that I'll stop there, and I look forward to the discussion.
Thank you so much, Dean Wright, for that really engaging discussion of environment and postpartum depression. So before we start the Q&A, and as you have questions, please use the Q&A to ask them, and we'll try to get to as many as we can. But before we start, I just wanted to highlight how you can get involved with our work at the Institute. Our community engagement corps, of which I am a member, is frequently invited to speak to community organizations, schools, PTAs, and decision makers about environmental risk factors and propose individual and community level strategies to reduce harmful exposures. So we encourage you to reach out to us to discuss how we can support your communities through education. We also encourage you to learn more about what we do at the Institute and to access our educational resources on the Institute's website, which is listed here, mountsinaiexposomics.org. And you can follow our social accounts at Sinai Exposomics to get real-time updates. And lastly, we offer a dynamic opportunity to join our advisory group, which plays a crucial role in supporting our work through philanthropy. Involvement can vary from backing research initiatives to leading educational community events. And so if you're interested in making a meaningful impact, please get in touch with us and we can connect you with our development office to explore the possibilities. And so with that, we will go to the Q&A portion of the talk. And I will take a look at some of the questions that are coming in for Dean Wright. So we have a question about the metals exposures and the associations that you see with PPD. And so the question is that you mentioned exposure to cadmium and chromium drove effects on postpartum anxiety. Can you comment on the main source of exposure for those metals?
Yeah, a lot of diet. There are, we talk about nutrition as a protective factor, but we also have to sometimes think about nutrition as a potential exposure factor. It's in a lot of these metals are in soil, et cetera. They also come from, a lot of them come through, they're part of the air pollution that we breathe. It's in the air. We talked about how there's airborne lead. We saw that map of the US, for example, doing it. Cadmium can be in cigarette smoke too. If you're a smoker, you can actually be exposed to that. We did actually adjust for whether or not moms were smokers, so that wasn't the driver here. We have actually relatively low levels of smoking, particularly in our Hispanic population, which seem to be at the higher risk, for example. So diet and airborne are the major pathways for those. And, you think about climate change. I worry about the metal exposures because we do know it's in the soil. And when soil gets redistributed, that can go into the air, right? When, you have winds, et cetera, major extreme weather events, droughts, you dry up riverbeds and other bodies of water. That soil gets redistributed, and people are starting to monitor that and show that we're getting more of these heavy metals, which become distributed because of those climate factors. So again, that's another thing. We need to understand these things now because they're only going to be magnified by some things that we're going to see from climate.
Wow. So another question is whether you looked at folic acid supplements and folate status in the study participants.
We haven't looked at that yet. I mean, the best way to do it, if we actually measure it, we do have report of folate. Folic acid they fortified a lot of our food supply with folic acid because we know that's a big thing for neurodevelopment, particularly for the developing fetus, but probably could have a role here as well. We have a report of intake of folate or taking folate supplements during pregnancy. Be nice to have that data before pregnancy. Preconception, that's the other thing. We really got to start before conception and getting them in pregnancy. If we can do that, that's where we can change some of these factors that might be protective, right? Make sure moms are taking or having adequate intake of iodine. I'll say something about the iodine because one of the reasons that they believe that iodine in insufficiencies are increasing amongst the population, including pregnant women, is because of the way different salt that we use, non-iodized versus iodized salt. So people, cook and eat and flavor their food more with sea salts and some of these other things that aren't ionized. So you're getting less. And actually, the difference between those two salts, not different in the sodium content that they're using, the way they flavor your food, etc. But you might want to consider using iodized salt because they have similar benefits. But having iodine deficiency has adverse effects. Let's see.
Yeah, I was curious if you could comment on the use of pharmacological treatments for depressive disorders during and after pregnancy. There's a specific question in the chat about using lithium as a treatment for bipolar disorder, and whether you looked at that. But also curious, if you could comment on whether you see risks and or benefits for the use of antidepressants.
Yeah. Well, as I mentioned, particularly people who have anhedonia are more recalcitrant to the treatments that we do have. So, lithium, helpful in bipolar disorder, may have differential benefit in a non-pregnant person in the non-peripartum period versus a woman who's in the peripartum period. These drugs may have different benefit or different efficacy, different ability to treat the disease. And that might be because that, for the reasons that women are probably more at risk, or we know they're more at risk for developing psychopathology, things like depression, both in pregnancy and in the peripartum period. A lot of that has to do because mom's physiology or biology changes, right? It has to while you're going through pregnancy to accept that baby, to nourish that baby, to grow and develop it adequately. Mom has all kinds of changes going on in her body. Her hormone levels, patterns are different if you carry a boy or a girl, for example. But also there are other physiologic changes that take place. Thyroid function can change, for example. And it doesn't snap back immediately when you have the baby, you deliver the baby. It takes some women longer to do so. Now, why is that? That's another reason why we have to understand all these environmental factors, because the environment that you're living in is going to also be pushing and pulling on those same systems. And it might be the environment that doesn't allow that to necessarily come back to a more optimal function that will minimize risk to psychopathology, but other conditions as well in the mom. It also has an effect on how well you might respond to drugs. So we're starting to understand that in all patients, we have to characterize their environmental exposures, because if you have a number of exposures in your environment, high levels of metals, high levels of air pollution, high levels of stress, all those things may enhance, say, oxidative stress in your body. Now I give the same drug to you as I do to somebody who doesn't live in all of that. They're in a much more optimal state with respect to oxidation, and they may respond very well to the medicine that we think should work in this setting, and the other person doesn't. Oftentimes we scratch our head as clinicians to say, well, we don't know why you're not responding. Maybe we'll try a different drug. But I actually believe very much so, and many of us are starting to look at this. It's your environmental milieu that's really changing how you might respond, if that makes sense to you. Another reason why environmental health and exposomics, and thinking about the environment on a much more comprehensive scale, absolutely needs to come into medical schools, medicine, all of our thinking. And that's why I'm excited to be, taking this position at Mount Sinai with public health, really marrying together public health more as broadly, but environmental health in particular.
Yeah, so that ties into another question about what resources are available to OBGYNs and women's healthcare practitioners to address environment and counsel patients. Do those exist, or do we need more of those?
We absolutely need much, much more of that in medical schools. So we need to be teaching, start as young as possible to start embedding, sort of this broad public health view, environmental health, et cetera. Particularly, we're we are at an optimal period to do that, right? Because everybody's getting more and more focused on climate change, climate effects, severe weather events, these kinds of things, the warming of the planet. It's going to change everything about our environment. It affects, we talked a little bit about it, how it might affect differential in growing air pollution exposures, metal exposures, etc. But it also is going to change our food chain. So our food chain is going to have less of some of the good things in our food, antioxidants, the ratio of good and bad polyunsaturated fatty acids. The people who study that in the oceans and our fish are already starting to see that because of the warming of our oceans, etc. So we you can start to see this is a big data team science approach. We have to all come together and be thinking about these things. We need to train our medical students, our public health providers, practitioners, researchers to really do team science around this together and help understand it together to really have an impact here. Every time I talk to and we do a lot of it, Sarah, your group does a lot of it. You create, educational materials, et cetera, that we can distribute to our folks that are seeing people in the prenatal period, preconception evenly, and postpartum period. Every time we talk to them, you find people who a light bulb goes on. They just haven't heard it before. They didn't get it in training, et cetera. So we have to start at all stages and continue the educational outreach. But the other thing about taking on this new Department of Public Health and the dean role of public health, I'll be working very closely with the dean for the Graduate School of Biological Sciences, the dean for medical education here at Mount Sinai. We're going to make sure that we integrate this more and more into those programs as well.
Yeah, that's amazing. I think, tying back to climate change, another impact is extreme temperatures. We had one of the hottest years on record last year. Maybe we're facing that again this year. And so there was a question about whether you've looked at the role of temperature or extreme temperatures on postpartum depression.
Yeah, and our models that we looked at, we do adjust for temperature over pregnancy as well. But what we're not looking at there yet is the exposures to extreme temperature. We don't have enough variability in the areas that we showed you that were the populations that we're looking at right now. But as we have ability, you think about that map of the US for the ECHO program that I talked about, we can start to look at a broader geographic area and hopefully start to think about those, because we do have that happening across the US. And it is measuring exposures to those spikes over time, extreme temperatures, right? It's not just an average temperature over pregnancy or some mean level over pregnancy over a trimester, et cetera. So I think that's very important. We do know that extreme heat, has independent effects of the air pollution exposure. So, climate's going to drive both the patterns of those things. And may have interactive effects. So it will be important to measure both. For example, heat exposure has been linked to adverse perinatal outcomes, low birth weight, preterm deliveries, et cetera. But again, that has not been looked at in relationship to maternal psychological functioning in this stage. So it's a good question, and it needs to be explored.
Yeah, there are a couple of questions about other types of exposures, and particularly thinking about other types of exposure disparities. We know that Black women experience higher exposures to potentially harmful chemicals through personal care products. Farm workers experience higher exposures to pesticides, for example. So have you looked at any of those other types of exposures, endocrine disrupting chemicals or pesticides, and risk of postpartum depression?
Yeah. It's been looked at in non-pregnant samples. We have not looked at it in this cohort yet, but where at the end I was saying we really got to take a more omics type of approach to use these types of assay platforms that can measure not just targeted. I'm going to measure all these these 10 metals, these 20 metals, et cetera. But this can give us hundreds to even thousands of different factors that we might be looking at through metabolomics, for example, in somebody's serum, that you take blood from a mom during pregnancy or urine, et cetera. We have those samples banked away. We can certainly do those. It's getting funding. Some of this stuff happens in an iterative way because you have to get funding to do it. It's not that we don't want to do it. We don't think it's important. The endocrine disruptors are a good one because you know that psychopathology, things like depression, anxiety, one of the key pathways that can get disrupted and lead to this is the hypothalamic pituitary adrenal axis, which kicks out things like cortisol, the stress hormone, but also the hypothalamic pituitary gonadal, so sex hormones. So disruption in sex hormone production, estrogen levels versus testosterone, et cetera, during pregnancy, already being disrupted whether you're carrying a male or a female. But if you're on top of it, somebody who has those chemicals in your body, you might be even more prone to that disruption that can lead to things like that. So that's a great question, and it should be explored more. Has been, but needs more work. But also, let's understand the endocrine disruptors at the same time. We're saying they're also exposed to all these air pollutants that can have overlapping effects, metals, nutrition, et cetera. That's what exposomics is. It's getting you closer to say, let's look at that whole soup and use tools like machine learning and artificial intelligence that can help us take that big data and make sense of it. But you still need the person who has knowledge of what those pathways might be and understanding what comes out of that. But we have those tools. So let's measure things and let's take advantage of it and really get a little closer to, ultimately we'll be able to boil that down for a clinician to do some, fingerprint of their levels of these things. And we can hopefully guide better. Oh, this treatment will work better in this person because there are these things going on, for example. I'm excited for that day to come.
Yeah, so we have questions, not surprisingly, we have a number of questions coming in from clinicians and others about, what are the big things that people can do to reduce their risk for postpartum, based on your research findings. We can't just move, most often people can't up and completely change their environment. So what are sort of your top tips for pregnant people to reduce their risk?
I think understanding we didn't talk a lot about it today, but it could have been a whole different talk to talk about the psychosocial risk factors and psychological stress. And we know that there are, providing supports for women that reduce psychological stress. One thing is to remove yourself from the stressors, but you can't always do that. But then there are buffers of stress. So strengthening your social relationships, social interactions. People have used programs like centered pregnancy. So when you see women coming in for their prenatal care visits, they're not just one-on-one seeing the providers, the healthcare providers, but they do it in a group of other pregnant women. And they found that actually that also gives support when you're being able to talk to people who are going through similar things for you, and they're people from your similar communities, et cetera. So programs like that, and people are studying that and the health effects of that. And one thing it does affect is psychological well-being in those new moms. And then there's nutrition, and that's another lever that we can pull, right? If we know that iodine insufficiencies is something that is going to either compound or protect against these things, even though when you're exposed to those chemical exposures, we need to be screening for that and looking at that. And iodine's one example, but there are other micronutrients that we can focus on there as well. So those are a couple of the things I think that we can think about as clinicians. And, we don't have nutritionists in our clinics. I remember when I took care of, asthma patients, there's a lot of evidence that nutrition is beneficial there for lots of reasons too, but we didn't have access to those people. That's not what I'm trained to do. And it takes somebody who has the time to really take a look at an individual and make recommendations around that. So we need to bring some of those ancillary services back into our provision of healthcare, both social work, social supports, et cetera, but also nutrition, things like that.
Yeah, something else that strikes me in listening to your talk is that this research can help to reduce the stigma around postpartum depression and mood disorders in pregnant and postpartum women, so that they do access those kinds of supports that might be available. Another great question that came in is, you looked a lot at outdoor air pollution. How did you consider microenvironments or indoor environments of participants, and how much time they spent indoors versus outdoors?
Yeah, we do that with like daily activity diaries, et cetera, so we can adjust to some extent for that. The PM 2.5 that you have outdoors is not so highly correlated with what's indoors. So the way that we measure things, we can be confident that to a large degree, there's measurement error in lots of things we do. It is the outdoor air pollution that's important there. Indoor air is very, very important. And to your point, the more time you spend indoors and the types of activities that you do indoors, the way you cook, people have shown that a lot of folks who do a lot of frying, for example, there's lots of things that are released into the air that you're going to be exposed to, including PM 2.5. Tobacco smoke, indoor tobacco smoke, is one of the biggest drivers of indoor air pollution. So we do adjust for tobacco smoke, household tobacco smoking in our samples to get around that a little bit. But people do measurements of indoor air pollution and find independent effects and maybe joint effects of the outdoor air pollution. So again, that's another thing. Measuring more comprehensively the environment that we're exposed to find out what are the drivers in particular people. So we do need to get to that as well. Asked about choline. I see a question on that. Choline also, there's a lot of inadequate intake of choline during pregnancy, and that's another one that's going to be a focus area for nutrition.
We have another question about another area of research at the Institute that I thought maybe you could comment on, which is whether anyone has looked at the microbiome and postpartum. Less healthy vaginal microbiome is more common in Black women, also associated with higher exposure to air pollution and greater risk of depression. So do you see any connection there between microbiome and postpartum depression?
Yeah, we have not looked at that. There are folks here at Mount Sinai, and more broadly, people are very, very interested in the vaginal microbiome for both maternal and child health outcomes. It can have impacts on both. So that's a very active area of research, and you're right. It's different across different economic groups as well as racial ethnic groups as well. And African Americans in particular are impacted there differentially, per your question. That's true. All that's true. I would have to look. I don't want to say what I do or don't know about looking at that in relationship to peripartum or perinatal mood disorders. I'm going to say I know I've seen some work on that, but not enough work on that. And that's an important one because it has implications for how immune functioning, right? It has an inflammation, et cetera. And those are certainly mechanisms that are going to be operating here for how it affects brain as well as other organ systems in the body. So that's a good question, and we should look into that more and see what's being done and what gaps are there and what we can add to that as well. We have a lot of experts looking at the vaginal microbiome across our health system.
So we have time for one, maybe two more questions. I don't want to overlook a question asking about preterm delivery and whether you see any associations between, we know that environment impacts gestational length. Do you see any interaction between preterm delivery and affective disorders in pregnant women?
There is a link, and then you got to sort of, what is it because of what happened in pregnancy that might be more fundamentally biological changes that might be related there. And it's shared vulnerability, right? It's the same factors that might affect mom's psychological well-being and affect the central nervous system because of those exposures during the state of pregnancy are going to perhaps put the baby at risk for being born preterm. So we know that air pollution exposures, for example, have been linked to both lower birth weight and preterm delivery in infants, so adverse birth outcomes, as well as metal exposures, as well as psychological stress, some of the things we've been talking about here today. And then there's postpartum. If there's a lot more stress in somebody who's delivered a preterm baby, particularly early preterm, right? Because you have a whole different experience of that postpartum period, et cetera. So it's always tricky to tease out which of the two it is, but I think both are operating, and we need to understand that as well.
All right, well, we are 1 minute over, actually, the top of the hour. So I want to thank you, and thank you on behalf of all the attendees. There were many thanks and accolades in the Q&A. And so if attendees can use the link that was placed in the chat to complete a very brief evaluation of today's programming. And you can also find links to access some of our educational materials. So thank you very much, Dean Wright. This has been a really great presentation.
Yeah, great discussion. I appreciate all the questions. It shows how interesting the area is and the gaps that we need to try to understand here.
Yeah, and there are more questions, and so maybe we can, write up a little synopsis and make sure that all the questions were answered.
Absolutely. Great. Thanks everyone for joining again.